dear audience. My name is Kinga Budai, and I am a clinical hospital pharmacist in Semmelweis University, in University Pharmacy, and in the pediatric clinic. And my supervisor is Csaba Lódi, my scientific methodology supervisor is Mahmoud Obaidat now, and my statistician is Szilvia Kisdala. I am involved in the work of the pediatric intensive care unit. So my vision is to improve the effectiveness of antimicrobial therapy in critically ill patients. And to accomplish my vision, my mission is to improve the antibiotic dosing based on serum drug levels and scientific results. So my two projects aim to investigating the advantages and disadvantages of extended infusion of beta-lactams. I start with the first project. So the misuse of the antibiotics is a real problem in medical world. Beta-lactams are time-dependent antibiotics, so it is crucial to maintain the plasma concentrations level above the minimal inhibitory concentrations. And to achieve this goal, we have three types of administration: the short-term infusion, the extended infusion, and the continuous infusion. And several pharmacokinetic, pharmacodynamic studies and meta-analysis among adults showed that the extended infusion was associated with a significantly lower mortality rate, so it is better. However, we don't know whether the extended infusion has the same effect in children. So our aim was to evaluate the clinical efficacy and safety of extended or continuous infusion of beta-lactams in children. We used the PICO framework to answer this question. Our outcomes included clinical outcomes such as mortality, therapeutic effectiveness, length of stay, adverse events, and so on. We conducted a systematic searching for databases twice, so we repeated it, and we found 38 eligible articles, and after that only 25 articles were included in our systematic review and 19 in our meta-analysis. And I will show my most important results. First one is the all-cause mortality is our hardest outcome. Subgroup analysis was conducted among RCTs and non-RCTs. In my opinion, the population was heterogeneous because of the different ages and different origin of infections. For example, they suffered from meningitis, gram-negative bacteremia, neonatal sepsis. And we used the odds ratio to measure the effect. If it is less than 1, then the event is more common in the bolus group, and it is 0.74, and it is a significant and clinically relevant result. So it means that the extended infusion was associated with significantly lower mortality rate in overall. After that, we investigated the infection-related mortality. We could include only 4 articles, but the population was homogeneous. Every patient had multi-drug-resistant gram-negative bacteremia, and the odds ratio is 0.52. So it means that 50% less deaths occurred in the extended infusion group. It is a very promising data, but due to the small numbers of studies and patients, further investigation is needed in this topic. And how can we explain these results? So we investigated the microbiological eradication, which is also an objective tool of efficacy. Unfortunately, the population is small. It is an underreported data, but the odds ratio is 3.18, and it means that in the extended infusion group, we could achieve an early microbiological eradication 3 times more likely. So it can explain the better clinical outcomes. And finally, we checked the adverse events. We could distinguish 2 types of adverse events: the acute kidney injury, the hepatic adverse events, and the odds ratio is near 1 in both cases. So it means that there was no difference between the 2 groups. So the extended infusion is as safe as it is considered as safe as the short-term infusion. In summary, our strengths are the rigorous methodology. It is a hot topic in a vulnerable population, but we have limitations, the limited number of trials and cases. We included observational studies too. The population was heterogeneous regarding comorbidities, age, concomitant antibiotics, and we had missing data, for example, in the field of microbiological culture or therapeutic drug monitoring, and we assessed the high risk of bias. In conclusion, the extended infusion of beta-lactam showed a significantly lower all-cause mortality rate and a significantly earlier microbiological eradication rate, and it seems to be as safe as the short-term infusion. In implication, the extended infusion can be considered to use in practice, and further high-quality RCTs and therapeutic drug monitoring are necessary. And our article was published. Okay, and so I mentioned this further investigation is necessary, and this is our next goal. So we already know the delivery options of beta-lactams, and pharmacokinetic studies support our think that the extended infusion is better than the short-term infusion. Aromatase showed benefits, but with limitations. And we would like to conduct a high-quality study to decrease these limitations. So the PICO framework is very similar to the first one. And as inclusion criteria, we would like to include pediatric patient with suspected or proven infection, and critically ill patient. The beta-lactams with meropen, ampicillin, cefepime, ceftazidime, ceftriaxone, they can be measured in the laboratory. So a proven infection means that they had a confirmed infection, confirmed culture positivity, and the suspected infection means that the patient has some signs of infections. Exclusion criteria, there are, for example, we would like to exclude palliative patients with altered kidney function when dosage adjustment is necessary, and patients with extracorporeal therapy or therapeutic plasma exchange or beta-lactam allergy. Basically, we will have two groups, the extended infusion groups and the short-term infusion group, and we would like to stratify the randomization by age and handle the neonates and the older infants and children separately. Our primary outcome will be the pharmacokinetic target, so we will measure the minimum concentrations or the trough concentrations, and the measurements will be done in steady state. And secondary outcomes, for example, a higher target achievement and clinical outcomes such as mortality rates, clinical response, when the patients reach the clinical success, the duration of antibiotics, treatment failure, microbiological eradication rate, adverse events, and so on. And now we are somewhere here, so our documents are under discussion. A summary. My two projects aim to ameliorate beta-lactam therapy in critically ill patients, and I would like to thank you for your attention with a quote, "Only love and not reason yields kind of thought."
Congratulations, it seemed to be very useful. My question is, what is your clinical practice?
My clinical practice?
Clinical practice of extended or bolus?
Honestly, in the pediatric center, we use the short-term infusion now, but So I mentioned that we would like to conduct an RCT in this field, but it is a little bit different topic, but I had measurements in patients who had renal replacement therapy, continuous renal replacement therapy in the PQ, and so the experience was, for example, in the case of meropenem, that they didn't reach the target, so they had a very low concentrations, and they received the infusion, short-term infusion.
At the second project, you already done the patient size calculation to tell anything about the superiority of the longer term infusion or not. So what is the number what is the number of observations you need to make?
So our sample size calculation based on the primary outcome.
And what is the planned primary outcome?
This is our primary outcome. It means that so the minimum concentrations should be above the minimal inhibitory concentration.
Okay.
So throughout the whole dosing interval, so we give a dose, we wait for the next dose, and before the next dose we measure the concentration, and it should be above the minimal inhibitory concentration.
Okay. So this is a very abstract
yes,
outcome, so not a clinical.
And then summarize the data in the literature, adult data, pediatric data, and.
Okay. And then, how many observations you need to do?
Around 100.
100. Okay. And the study is planned. This is a single center study.
Yes.
Okay.
So the pediatric center with two departments.
But what is your expectation? You know well how much of these antibiotics is used, so it takes 2 years, 3 years?
Hopefully 1 year.
1 year, okay. Okay, great.
If you can include patients in NICU in your department, then, then hopefully it will be 1 year.
Okay, of course. Great. And the other division is involved, so this ortho street. Oh, yes. Great. Okay, nice. Thank you.
Yeah, thank you. Thanks again, nice presentation. Your primary outcome, could you comment on how would you theoretically think how kind of a good an indicator is MIC based on then what you would expect on kind of the clinical efficiency? So can you comment a little bit?
So how can we measure the MIC?
Yeah, kind of if you are thinking about beta-lactams, which generally can have kind of a wide therapeutic breadth, and you have a defined MIC value, how good a number is that? So how informative a number is that? So what you could then expect on how it would translate to the clinical outcomes?
So may I help? Probably your question is that what MIC what the clinical probably you can translate the MIC for a clinical. What is the clinical value of this information? What does it mean clinically?
So probably we can reach the microbiological eradication rates in early phase, and this contributes to the better clinical cure and efficacy.
So probably do you mean that this is the point when the patient turns into a safe condition because there is a bacteriostatic effect so this is the onset of the bacteriostatic condition, probably.
Yes.
Something like this.
bit elaborate this. So can you comment on the specific specific clinical conditions, specific infections, and is this, I mean, is this likely to vary based on the clinical conditions if you kind of are aiming at including a wide range of ill children, including neonates?
For example, so late onset sepsis. So in this case, we generally use beta-lactams with wide spectrum, for example, meropenem, and yes, and piperacillin tazobactam. So these are the most common used antibiotics. Yes, and we had a subset analysis among neonates also, but I couldn't show it in the case of mortality, and this was a statistically significant result. And all newborns received meropenem antibiotics. So especially this population
in late onset
sepsis, yes.
I'm sure that you are searching for positive cultures and for the resistance, and after that you choose the best beta-lactam, and you are searching for the outcomes in these situations, right? After resistance testing.
Not exactly.
Not exactly? Okay.
So, so our plan is that, so there is a very sick patient, critically a patient with sepsis, and it is necessary that we give antibiotic promptly in this case. And we think we can delay the randomization because of this situation, and so our plan is that we can include patients with a planned antibiotic initiation or when the therapy was started, but within 24 hours.
Okay.
And when we detect the patient, then on the first day or 0 day, I don't know, we will take culture samples and measure it, but of course the results will come later.
Of course.
But we can adjust the antibiotic therapy. So the first choice is an empiric choice, and after that, of course, the most important thing, the patient, so we can change the antibiotic if it is necessary.
Okay, then
we will evaluate the microbial eradication rates in different time points. So on first day, of course, when we start the therapy, and second day, third day, and 5 days.
Okay, I understand. And what do you think? There could be a difference between the different beta-lactam antibiotics? So are you waiting for different results, or you would like to do a subgroup analysis on the different types of antibiotics, or you pull together all the beta-lactams?
We will put together, but if we have a lot of data, then we can do subset analysis, but basically we will put together.
I saw a lot of outcomes, but which values or outcomes will be assessed every day?
For example, the adverse events will be assessed, CRP levels, and clinical response. So every day we can assess the resolution, or if the patient has resolution or improvement of failure. So these types of data.
You mentioned the degradation of the antibiotics on the long-term infusion. It's usually considered as a problem. For example, with aminopenicillins, it's very fast, and you plan to use some aminopenicillins and meropenem as well, which is known to degrade when it's in the solution. Would you plan to address it somehow, like measure with the solution content after a while, or any address on this?
Thank you for your question. We don't plan to measure it, but of course I read the SPCs, the summary of product characteristics of different drugs, and these reports the stability of the drugs. So that's why we choose the 3 hours extended infusion, because due to this data, the meropenem is stable, and the other antibiotics are also stable. They are stable longer, but yes, the critical point is the meropenem antibiotic.
Every 3 hours you change the...
We
so
are
it's not
planning
continuous?
extended infusion.
It's an extended, not a continuous.
Only,
okay.
Not continuous, only extended 3 hours infusions.
However, with piperacillin it's a bit less, I guess, but it's only 2 or 3 measures that you should make, and then you can validate it. But if you have the data, then you can decide based on that as well.
I was wondering, how can you justify why children should be analyzed separately from adults in these regards? So any PK/PD differences which would make it kind of suggest that we should analyze pediatric data separately?
So the newborns and the older?
No.
infants?
Children, adults.
Yeah, oh. Yes, it's a good suggestion. Yes, if we have enough data, I think it is...
No, sorry, it's just a theoretical question. So how would you explain why is it important to analyze these data separately? So I don't suggest that you should collect data from adults.
Because of the pharmacokinetic alteration.
Can you name a few? Or
yes, the renal clearance and liver metabolism. So based on my knowledge, for example, at 3, the liver metabolism is higher than in older age, so it can be a difference. And the renal clearance also can change during the life.
How do you plan to get parental permission? So typically the situation is a late onset sepsis or an emergency situation to start antibiotics. And in a late onset in hospital environment, it's very hard to tell the parents, a frustrating one, that, oh, this is so sorry that there is a high suspicion that your baby started a late onset bacterial infection, and okay, but if we perform a clinical trial, and please allow to us to make a random choice to give a new, very hopeful type of administration or the standard. So this is psychologically is a quite complicated situation. Do you have a plan how to get parental permission?
Yes, I totally agree. So we permit delayed consent. That's why I write this sentence, the start of the therapy within the previous 24 hours, so we can start the therapy, and after that we have 1 day to get the consent and start the randomization. And after that, of course, we have to wait for the steady state.
If the therapy, so not the first dose is randomized to...
No, so the first or the first 3 doses, I don't know.
Great.
In 1 day,
okay.
They will be short-term infusion or as usual care, and after that the patient will be randomized, and of course it can influence the plasma concentrations, but we will wait for the steady state, and so it cannot distort our data.
So based on your plan, the different type of administration will start after 24 hours of a standard regime. Great idea. Great idea. Thank you for the clarification.